And we go on to the next speaker, Dr. G. Sridhar, interventional cardiologist from Manipal Hospital, Old Airport Road, Bangalore. He is going to talk about the drug in focus, that is Inclisiran, emerging science and clinical practice. Dr. Sridhar.
Thank you, sir. So you all understand it's a pre-lunch session. I'll be as precise. So the associations have been giving LDL targets in the context setting. It's no more the levels, it is the risk which is associated with the patient. So the higher the risk, get the LDL as low as possible. And we have statins, but are statins enough? No, because statins have their own limitations. Dose escalation leads to side effects. So non-statin medications have come. A lot of them are there, the oldest being ezetimibe, which came in early 2000, then disappeared, and again getting back into the business. Then bempedoic acid, which is a new addition. And other than that, PCSK5/9 inhibitors have come, everlucimab, etc. And now is the era of some small interfering RNA, which go up to the genetic level into the cells. So modifying the receptor level of LDL uptake, which will help you in achieving that target which the guidelines are recommending. So why it becomes important in our country? In particular, we are the coronary artery disease capital of the world. We have an estimated prevalence of coronary artery disease in millions, 50 millions. And it is the number one killer in our country. And years are lost, and it's a big burden. And it is 70% higher as compared to the Western population. I mean, disgusting. So why? Because it has a higher risk in our country, develop it at an earlier age, and exhibit a very severe aggressive form. We are seeing even 30 years, 35-year males, younger age group coming with aggressive disease, and obviously the outcome of these patients are very poor with revascularization or whatever strategies you apply. So it's a major risk in the intra-heart study if you see. You know, we have other risk factors also, hypertension, diabetes, central obesity, almost everything adding up to 50% in addition to the extreme dyslipidemia we have, and we have very high vulnerable risky population. So now we all know about what is called smoke years as far as smokers is concerned. This is a new concept which is coming. This is LDL cholesterol versus years, that is milligram years. It is multiplicative. So multiplicative and so threatening that every 1 millimoles per liter increase in LDL level, risks of your acute coronary event, MI, become 30% more higher. So it's in a multiplicative proportion. So LDL is our enemy. Of course, there are other remnant components like ApoB, which I am not going to concentrate here because it widens the topic. And hit it hard when it is hot. Hit hard, act hard. That's what is the thing which is now the new proponent. Why? You have STEMI, or you have ACS, you have PCI, you have revascularized. That's not the end of it. If you don't follow the LDL, if you don't follow the lipids, if you don't see them in next 100 days or 3 months, 1 in 10 patients are going to come back with a second event. And the registries have shown that the rates of death and recurrent MACE events are exceeding 10% in 1 year. That's why it becomes very important to hit them hard. That's why the concept of repeating at 8 weeks, 4 weeks is coming back. So what is the world data? Are we really achieving the targets? In spite of, statins being there, ezetimibe being there, and the need for intensive lipid-lowering therapy has come because across the population in the world, the non-achievers are close to 70-80%. In spite of, good medications available, the guidelines available, and the education available, we are not able to reach. In our country, we are no better. There was a study in 11 centers, and 79% of the people failed to achieve the targets. So there is a considerable gap in dyslipidemia management with respect to our country. So what do statins and other drugs do? See, rosuvastatin can, at highest dose, reduce it to around 50%. So does the atorvastatin. And these are all the data of ezetimibe, bempedoic acid, etc. So if you combine statin and other drugs with PCSK5/9, it is going almost up to 75%. See, I think amongst us, Our average LDL across the population, I'm very sure, is above 100. So if we are high risk people, amongst at least 10% of us may fall into high risk here, where we have to achieve an LDL of around 50, or in very high risk patients in category C even 30. It's not possible with statin alone. You may have to push the doses to very high levels, getting into complications. So that's why, non-statin lipid-lowering therapies become very important in high risk populations. So this slide has been shown. You see this, the extreme right. To get an LDL level of 30 is not very easy in a very short span of time with statins alone. And the risk factors are adding up. The classification system is making it more and more aggressive to get the LDL to around 30. And is it dangerous? No, because other associations are also recommending the same, especially in ACS situations. What they are saying, non-statin LDL therapy, which is STMI, PCSK9, bempedoic acids, are all recommended into class 1. So even ACC is saying the same thing. And what is the problem? Our patients in a real world data have not achieved the LDL cholesterol levels at all in spite of the aggressive statin therapy. Only around 20% of us after a event have achieved the LDL goal, and 80% of them do not achieve at all in spite of the statin. And then not only achieving, are you continuing to be on statin at least? No. 50% of patients in the data provided discontinue their statin, and only around 25 to 30% of them are there on statins by 2 years. And majority of the statin discontinuation happens in the first 6 months, which is the hottest period where the statin is required the most because of its pleiotropic protective effects or anti-inflammatory effects or anti-ischemic effects, whatever it is. That is why there is a need for a newer lipid-lowering therapy as an adjuvant therapy to statin to get our patients, or at least very high-risk vulnerable patients, into those lipid LDL levels. So if LDL is the enemy, LDL is a rogue in our body, get rid of it. That is the thing. So this new drug has come up in addition to the PCSK9, which we are exposed to for quite some years now. It's a small interferon RNA therapy. It's an injectable medication. And what it does is it goes and acts at the cellular level. It prevents the synthesis of the degradation enzyme of the LDL receptor, that is the PCSK9. The amount of PCSK9 reduces, your LDL cholesterol receptors are higher in the liver, and the uptake of LDL becomes more. This is the cellular level of action. I don't want to go into it. So it is, in essence, it increases the LDL receptors in the liver, which recirculates the LDL. Simple medication. It is a 1.5 ml solution with water dilution, and it is subcutaneous injection, and administration is just like insulin. The dosage is at the 0, 3rd month, 6th month, and thereafter every 6 months. And this is what it is. If you are on statin, of course you have to be on statin when you are taking other lipid-lowering therapies also, but statins have to be taken at aggressive doses throughout the year, every day. Whereas your PCSK9, you need to take it for 26 days in a year, whereas this new molecule Inclisiran, you need to take only twice in a year. The idea being that you will be more consistent. Something is better than nothing, because taking it halfway, 10 days, 5 days, 20 days will not help unless until the LDL levels are lower in a sustained way throughout the year. So how the evidence comes? There are lots of evidence, phase 3, phase 4 trials. They are called Orion group of trials, which is there from 8, 9, 10, 11, 4, etc., where Inclisiran has been studied in different subgroup of patients, like in this heterozygous familial hypercholesterolemia. 50% reduction of LDL was demonstrated, and that almost the same reduction was sustained in the follow-up. This is a Orion 10, where there is an established atherosclerotic coronary vascular disease patients, where again a 50%, more than 50% reduction was demonstrated and sustained. And in Orion 11, in patients with atherosclerotic coronary vascular disease and also atherosclerotic coronary vascular disease risk equivalent patients, again there was a consistent reduction in 50%. What is this showing? That this drug is getting the LDL cholesterol lower more 50% than what an aggressive statin can do, over and above the statins. And sustained efficacy is also proven in Orion 8 as a continuation of the study subsets of Orion 9, 10, 11, etc. This is a busy slide, but otherwise what it says, that it is not one of the dose effect. If you continue to give this medication, there is a sustained reduction in LDL cholesterol levels, which has been shown over more than 500 days, more than 2 years. And in whom it is shown? Across all the population, whether it is a chronic stable patient population, or whether it is an unstable population, or whether it is a recent MI, whether it is remote MI, across the risk population of the patients, the reduction of LDL cholesterol is aggressive and is sustained. So there are again multiple studies which have shown, I mean, as a cutoff point, or as a drawing what we call inferences, which have shown cardiovascular outcomes to be favorable. Of course, if LDL is the enemy and if you are getting the LDL down, your plaque has to be less, your event has to be less, your outcome has to be good. That's how your CV events come down. But the problem is we do not have a head-to-head placebo-controlled CV outcome data till now with this drug. Of course, there was another Victorian initiative which said that why don't you initiate this drug up front? The guidelines usually recommend statin plus ezetimibe plus other lipid-lowering therapies, and then you come down and chalk onto this PCSK9 or Inclisiran. But there is an upfront trial which said that in all patients who are statin, patients who are naive, please start Inclisiran also, and that has also shown very aggressive reduction in the reduction of the LDL cholesterol. And the worry is how low can you go? This slide was shown, and the recommendations by our own Lipid Association of India is to go in extremely high risk patient category C to as low as 30 and below 30, which is absolutely not possible with statin alone, in spite of adding statin with other bempedoic acid or other lipid lowering therapies. The need of the hour is a very aggressive medication. Why it is very important? The lower the LDL level, the lesser the events, whatever is the strategy. So Inclisiran, how it has come in, our own CSI has put this drug into guidelines, as was shown in the guideline of 2023. If you are not able to achieve an LDL cholesterol of less than 55 in a high risk patient, you need to add these newer PCSK9 inhibitors or the Inclisiran. We have to still wait for this trial to come. This is a trial which is in outcomes are in waiting, Orion 4. This being conducted with Novartis in association with Oxford University. High risk atherosclerotic cardiovascular disease, established or treated patients, past or present. 16,000 subjects are randomized so far. Randomization is complete and further randomization is stopped. Men, they have selected more than 40 years, women more than 55 years. May not be the context setting for our country because our CADs are coming to even 20s and 30s. But however, they are planning a follow-up of around 3 years. It's already now 2.5 years. The CV outcome data is going to be available very soon. Thank you.
Thank you, Dr. Sridhar, for covering that topic excellently. Now we request our very senior physician.
Okay, sir. Yes, sir.
Dr.
Sir, the health of a person depends upon the health of the blood vessels, whether it is coronary vessel, cerebrovascular vessel, or limb vessels. So the health of the vessel depends upon how much cholesterol is there, how much LDL gets deposited. So the treatment with the statins is a very, very important factor in both primary prevention as well as secondary prevention. In the primary prevention, somebody below, say about 30-35 years of age and no comorbidities, below 100 is okay. Somebody is a diabetic, I want it to be below 70. Suppose if there is a cardiac event, diagnosed coronary disease, it has to be 55. And below 30, if there are multiple comorbidities like stroke and a cardiac event, so lesser the better. We have to achieve it using the statins, estimate, and bempedoic acid, that Inclisiran and alirocumab, bivolocumab, these are all PCSK9 inhibitors. Availability, accessibility, affordability is an issue. But in those patients not responding to statins, we have no choice, we have to give it, and they are injectables. Sir has given me 1 minute, I have finished.
Thank you, Dr. Ra, for that useful, very comment.